Thank you so much, Judith. Hello, everyone. My name is Shauna von Blixen. I'm from the Council of the Baltic Sea States. We are an intergovernmental organization, and we are also the lead partner on a project called Promise. And while the presentation loads, at least on my screen, I'll just continue. Actually, that's difficult. The first slide has a very important image that you need to see. But anyway, I will say that Promise is supporting the growth and expansion of the Barnahus model throughout Europe and even beyond. And the Barnahus model is supporting child victims and witnesses of violence to have a child-friendly setting, a safe and professional environment to tell about their stories. And I just changed the slide. Maybe you can see it. I still don't. If you can see the slide, there is an image that shows a number of professional groups which are organized under one roof. And that really is the key here, that in order to arrange services with the child at the center, to really support the child in this time. Oh, good, you can see it. To support the child in this time, it's vital that the services all meet the child in one physical place, literally under one roof, a one-stop shop. When children go to a Barnahus or a similar setup and have an interview, the interview is usually recorded, and this recording may be used as evidence in court. And of course, for some cases, it may be possible to collect physical evidence. And this is where a medical evaluation team that is regularly on site and part of the routines at the Barnahus becomes vitally important. Beyond that, of course, a medical evaluation is so much more than just evidence gathering. It's also an important part of the healing process, both physically and mentally. We talked a little bit about that in part 1 of this mini-series last week, and I'm sure we'll hear a bit more about it today and also in part 3 in a few weeks from now. This mini-series is part of a bigger series, From Zero to Barnahus. This series is inspired by the first phase of the Promise project, which explored the standards and criteria of Barnahus and similar setups. Oh, here we go. Yeah, now I see it. Good. So it explored the criteria for Barnahus and similar models in depth and developed standard-setting publications. And key professionals from around Europe were invited to take part in this process. Now, with this webinar series, it's an open invitation to join these discussions within the European Barnahus movement about these key principles, standards, and challenges to consider. And on your screen now, you see the publications that came from the first phase of the project, and these are the inspirations for this whole webinar series. The hero document, and one that we are referencing throughout this mini webinar series about medical evaluation, is the one in the top right there, the Barnahus Quality Standards. This one comes in a number of flavors. You've got a summary, an ebook of that summary, and the summary is also translated into many languages now. You'll find all of these and more at the Promise website, which is at the link in the web links. Just down below, there's a bunch of web links where you can go directly there. The format for today, we have one featured speaker and 1 or 2 contributing speakers. So the idea is that the featured speaker will speak until about 40 minutes past the hour, and then the contributing speakers will come to give their reflections and to participate in answering questions. Together they represent multiple countries, deep, broad background experience, perspectives, and we hope that this helps you to support your work. Our featured speaker today is Resmiye Oral, a professor of Paediatrics, director of the Child Protection Program at the University of Iowa in the United States. And she will have a bit more time to introduce herself as she gets started. We also have on your screen, you can see Stefan Rune, Karolinska Hospital University. He was the featured speaker in our webinar last week, part 1, Framework for Medical Standards. You can already watch it now. And the link is available somewhere. And we may also have Andrea Goddard with us from the UK. Her webinar is on 19th of November. We hope you join us. It's on sexual abuse diagnostic workup and decision making. Today we're talking about physical abuse, diagnostic workup, and decision making. And with that, I would like to invite Stefan Rune to turn off his video. And as I pass the floor over to Resmiye, I will just say two things. One, we really appreciate if you are participating in the chat and asking questions. If the speaker doesn't get to your question during her talk, then we'll try to get to them at the end. And also, depending on your professional background, you may or may not be used to seeing images of bruised children and such. So just, there are a few images like that coming up. That's nothing too graphic. If you are a medical professional and you would like to see the detailed photos, send me an email. I'll write my email in the chat here, and we'll get that to you directly. Without any further ado, Resmiye, please take it away.
Thank you. Well, good morning for me, and good afternoon for everybody else in Europe and even Eastern people from Pakistan. I see there's an attendee. Welcome, everybody. It's my pleasure to discuss this topic with you. So let me move on. Oh, I will have some slides of a variety of national parks in my presentation. That's how I have been able to keep up with the very difficult child abuse work all these years. So last week, Stefan very elegantly and effectively shared with us all the grayed out items on this first slide. And this week, I will try to walk you through the steps of diagnostic workup for specifically physical abuse and for victims of physical violence, recognize physical indicators of physical abuse, and develop a diagnostic interpretation pathway to diagnose physical abuse. I know that not everybody is a medical provider, but I believe because the work at Barnahus and in affiliated institutions that we do and we will do has to be multidisciplinary, all different disciplines in the equation should have a basic understanding of what everybody else is doing in the collaboration. And that is why there will be a little bit of medical information here. But it's going to be as basic as possible too. So we are dealing with victims of physical violence in addition to other forms of violence when it comes to the clientele that will come to Barnahus and its affiliated institutions. Okay, so those that may have mild symptoms of physical violence and who are medically stable with a few bruises or fractures and things like that may indeed be handled in the Barnahus outpatient setting. But there will also be severely injured and medically unstable victims of violence. Those children cannot be handled in the Barnahus setting because it is an outpatient setting, and these children are not going to have, these children will need a comprehensive hospital setting, and a lot of times in inpatient setting. And that is the basis of my point. If from this presentation you forget everything else, I hope you will remember that every Barnahus that is not established in a hospital setting must develop an affiliation with a hospital where the severely injured victims of physical violence can be treated and forensically evaluated, just like we do mostly for sexual abuse cases and milder forms of physical abuse, and victims of or witnesses of violence are being evaluated in the Barnahus setting, as you see here. So We know that Barnahus will work with the police, child protective services, and the prosecutor in a multidisciplinary interagency collaboration. But I would like to stress one more time that the other link of the collaboration must involve a hospital setting, which will collaborate bilaterally. It's not only going to be Barnahus referring patients to the hospital setting, but it will also be the hospital referring patients after the initial treatment is done for forensic evaluation at the Barnahus setting. So first I would like to understand how many of you are already working for a Barnahus? Okay. All right, people are discovering how to do this poll. Okay, it looks like most of you are not working for a Barnahus at this point. Okay, thank you. So looking at how a hospital child protection team should be organized, the core of the team should have a medical component, medical provider. It may be a pediatrician, family practice doctor, forensic medicine physician, any combination, but a medical provider supported with a nurse is very important. And then the hospital should have its own social work support for the child protection team. And in especially developing countries, my experience showed me that psychology and child psychiatry are usually involved in this core team to support the forensic evaluators. And then around the circle is other providers, especially for physical abuse. The red highlighted ones, ophthalmology, radiology, orthopedics, pediatric surgery, neurosurgery, forensic pathology, may be more involved with the core team to provide consultative knowledge to the medical providers of the child protection team. So how many of you already work for a hospital with pediatric inpatient units is another information that I'd like to understand. Okay, we're learning this poll. All right, okay. So very few of you work for a hospital. Okay, thank you. And so I hope those of you who don't work at a hospital setting will be able to reach out to your neighboring hospital and identify individuals who may be interested in working with you in collaboration to manage severe forms of physical abuse cases in the hospital, working together with you. So when a hospital decides to establish a child protection team, there must be a stakeholders planning meeting. And this meeting will involve all the disciplines that I showed you in the previous slide to address all of these issues in a stepwise manner. First of all, which cases will require a child protection consultation? How will the consultation system operate? How will the Barnahus and the hospital handle bilateral referrals, as I mentioned before? What kind of paperwork is going to be used during the consult to gather standard information on every single case. What kind of documentation devices and system we're going to use, especially to document the injuries observed on the child. How is the reporting going to work? Is it going to be through the Barnahus? Is it going to be directly to Child Protection Services and the police, or either one of these entities? That needs to be worked out in your own community based on your laws. And then what's going to happen during the post-consultation processes, and of course, when all of this is put into writing in a memorandum, then staff education will be needed across the hospital, across disciplines, as we will discuss. So those of you who work with a hospital in your community, please tell us how many of you already have a hospital-based multidisciplinary child abuse team that you work with. Okay, so it looks like only one person is associated with a hospital-based multidisciplinary team. In the chat box, can that person identify themselves and their country? I know who that person is. Thank you. So originally I am from Turkey. And you will see some slides from Turkey as well. So in terms of the hospital staff education plan, when all is put into a memorandum, creating a written protocol on how to recognize, evaluate, and manage physical abuse cases is extremely important. And for those of you who would like to have the written protocol that I developed for my own hospital, I'd be more than happy to share it with you. Training all relevant staff on the protocol, starting with the child protection team, is of paramount importance. And then nowadays we're living in a virtual time, so I'm pretty sure every hospital has a password-protected website. In that website, placing this protocol and even small flyers for the staff to tap into when a case hits the emergency room to find out what they need to do for the next steps may be extremely helpful. And in my setting, I provide education to all relevant residency programs on an annual basis, in part as part of their annual core curriculum lectures. Every residency batch, from surgery to family practice to pediatrics, emergency department, etc., receive a child protection clinical guidelines use lecture from me, so they know when a child abuse case hits their floor, they know how to access this web page and the child protection guidelines. So how do we diagnose abuse? First and foremost, suspicion is the first thing. And in order to have a suspicion, we should have a baseline knowledge of physical abuse. Then knowing what to do to recognize physical abuse, and finally arriving at a diagnostic decision. In terms of developing a suspicion, knowing, I don't know if you guys are seeing the risk factors boxes, but they're lost, unfortunately. So there are, perhaps you're seeing it and I am not, so there are child-related risk factors, parent-related risk factors, and community and society-related risk factors. And I'd be more than happy to send the slide to Shauna so she can send it to everybody. So another thing I would like you to remember after this presentation is to remember this triangle, which I came to call Oral's triangle. This is what we actually do in medicine with every single case. We obtain a history of trauma. We look at the child's age, the developmental level, etc. And we also look at the child's injury, illness, mechanism, and extent of that. And we put these three pieces together, and if they all fit and we can establish this concrete triangle, then it is fine. That means we have the diagnosis. But if we lose one side of this triangle, then that means something is not matching, and that is the point when we should have a suspicion for physical abuse, and we should look at the case a little bit more deeply. And when we look at these cases with concern for child abuse and neglect, especially the younger the child, the more detailed birth history, history of hospitalizations, any illnesses, emergency room visits, etc., information about those will be much more relevant and necessary. When we gather all this information, then we should identify when the child was last seen normal with the date and time of that status. And then from that point on, what kind of caretakers were involved in the care of the child, whether there were any triggers for abuse or not, what kind of events took place in a sequential manner. And finally, we get to when was the first ominous symptom of not being normal observed, and from that point on, what kind of interventions took place. We should gather all these pieces of information in great detail. Other indicators of physical abuse would include certain behavioral changes. Any extremes of behaviors listed on the slide, if the child is, walking healthy and healthy looking at least, and comes to Barnahus on an outpatient basis, these behaviors should not be taken lightly because they may have a meaning behind it. Your psychosocial history may reveal more to make sense of such behaviors that may be observed with a child. Obviously, these may be even more specific behavioral issues that we should pay attention to when we are considering child physical abuse. Then observations related to child-parent interaction or child relating to the caretaker. These may be very important as well. Physically abusive parents may bring their child to the hospital to get the injuries treated, but they may also be angry with the child that they find themselves in the emergency room setting or in the Barnahus setting. Or they may be defensive or aggressive, especially when you start feeling like the caretaker is trying to cover up something that should raise significant concern for physical abuse. Then we have the physical indicators of physical abuse that would raise concern for something not going right. For instance, if we observe bruises, welts, burns, and any unexpected mark on the child's body, that should be concerning. unexplained fractures or incidentally discovered fractures. A child comes in with bronchiolitis and you do a chest x-ray, and on the chest x-ray you see several rib fractures. Those are very concerning. Obviously, brain injuries, subdural hematoma, bleeding in the eye grounds, etc. And these children would be inpatient children, obviously, as well as the children with internal organ injuries. We should always keep in one side of our mind whether these might be inflicted, not accidental. And a lot of times, physically abusive individuals wait for the injuries to heal. Only when the injuries and the complications get so bad, they bring their child to the ER. This delay in seeking medical help should be very concerning as well. Then certain patterns of injuries give us the ability to recognize abuse. If the description of the injury, its type, severity, age, mechanism, etc., are not consistent with the history of trauma, remember the Oral's triangle, and or the child's developmental level, that should raise a very significant red flag. Injuries typical for inflicted injury, and I'm going to show you just a few slides toward that regard. Injuries with no history of trauma. I fed the baby, put him in the crib, and in 2 hours I came to check on him. He wasn't breathing, and the child has bleeding in the brain, bleeding in the eyes, and in coma. Pattern injuries that indicate the use of an object and multiple injuries at various stages of healing may be extremely concerning. So this slide, for those of you who are not medical providers, may not mean anything to you. But for the medical providers, I have to show you that, I don't know if you're seeing my moving arrow, but the 4 arrows on the 4 side show healed or healing rib fractures, as well as the 6 arrows on the left side. In addition, this child has 2 on the right side and 3 on the left side, healed old rib fractures, and a good radiologist would also catch the very severe healing arm fracture on the right shoulder. So even if this kind of a child has multiple accidental trauma history, I would be extremely concerned for physical abuse on this child, and definitely report this child to Child Protective Services. And these 2 are referring to newer rib fractures, acute rib fractures. And this child has a very severe posterior rib fracture and another one on the left side as well. So, oh my goodness, this slide is totally missing my beautiful pictures. Okay, well, I know from my presentation that this slide was supposed to have shown metaphyseal fractures, which are corner fractures at the end of joints. So these are very specific for child abuse and neglect. And with rib fractures, one of the most significant and specific abusive fractures. Okay. So in order to identify all of these, our diagnostic workup will include what we call a skeletal survey. And skeletal survey means the arms, the hands, the legs, the feet, the chest, the pelvis, the spine, the head, the neck. All of these structures are going to be x-rayed on dedicated x-rays so that we can see all the details of possible fracture sites. And if we are concerned of skeletal injuries in a physical abuse case, repeat skeletal survey, especially in children under 1 year of age, is highly recommended, and your medical providers should know this. Uh-oh. I am so sorry. I don't know what's going on. All my images are gone, ladies. So this was showing the skeletal survey images consisting of about 16 images, at least 16 images. Okay, there's a question here. I think we're going to take the questions at the end, right? Uh-oh. Shauna, is it possible to send the handout to everybody so they can open the images? Because this is not going to work because all the images are missing. And I'm going to open my own presentation on my computer here in a second because I have memorized some of the images even when the images are not there, but not all of them. Okay. All right. Where are we? Okay. Okay. So, yes, the slide that we're not seeing right now, which is slide 30, when you get the handout, is showing 2 x-rays that are not appropriate images. One is a skull x-ray with multiple probes on the skull, and as a result, if there are any skull fractures on this image, we wouldn't be able to see anything whatsoever. And then the other one is a chest x-ray with a side marker, right side lead marker, covering the entire right chest, and no rib fractures on this x-ray on the right side would be appreciated, unfortunately. So I am moving. Okay, so the text slides are showing fine, but the image slides are not showing, it looks like. So the next slide, slide 31, walks us through the diagnostic workup in acute head trauma, which obviously should be admitted as an inpatient to the hospital, and that's why your Barnahus must be working with your hospital. Head CT is done during the acute phase, and head MRI is done in subacute and chronic phases. Okay, again, our images are missing. Under the CT images, there would be 4 CT images showing acute subdural hematomas on the top 2 images and severe brain edema on the lower 2 images, and brain edema means brain swelling. And the left-sided images are also showing various kinds of bleeding in the brain, and the lowermost 3 images, which are called 3D images, are showing the skull fractures, depressed and linear skull fractures. So, am I just moving on? And then the next slide, which is slide 33, Okay, Katerina, you have control of the screen, I understand. So slide 31 shows us MR, magnetic resonance imaging, MRI images of the brain injuries specifically. And these are, again, bleeding in the brain, swelling of the brain, infarction of the brain, a variety of injuries that your physicians and your radiologists would evaluate together. So I'm moving on slide 34, which is a text message again. I don't know if you're seeing it or not. There's a, okay. Is it okay if I move on? Because I'm not seeing anything on the shared screen right now. I'm just moving on with my own slide presentation. So the diagnostic workup in severely injured comatose children and those with clear abdominal or chest injuries should have chest and abdomen CT as well. And in addition, a variety of blood tests will need to be done, which will be important for your physicians. And moving on, I am now on slide 36. Urine tests, hair tests for drug toxicology is routine in the United States, as well as end organ tests, including the liver, the kidney, the pancreas, must be done as well in severe injury cases. And especially in abusive head trauma cases, we also do metabolic and genetic tests, in addition to ophthalmology consultation in abusive head trauma cases to see whether there's bleeding in the eye grounds or not. I am moving on. And finally, in terms of diagnostic workup, genetics consultation is done to rule out genetic conditions. And in severe neglect cases, which may need to be admitted to the hospital also, there's a number of additional tests that need to be done. Especially severely neglected children usually have developmental delays as well, and that needs to be worked up too. And finally, in failure to thrive cases, nutritional assessment should be done. So, okay, it looks like it's in my hands again. Oh, okay, so some images came up. These are the skull fracture images, if you're able to see them. Okay, MR images are not seen. We went through this already, and we went through this slide already, and this is the retinal bleeding image. Okay, so what makes us suspicious? If there are too many, too big injuries in too young infants, bruises in protected areas of the body, which I'm going to show you, pattern bruises indicating the use of an object, black eyes without appropriate history, bite marks, and bruises of various stages of healing on body sites with similar structures would be very concerning. A very wise team of researchers developed this 10-4 acronym. 10 stands for T for the torso, the chest, E for the ears, N for the neck, and 4 is a child under 4 years of age, and any bruise on a child less than 4 months of age. Okay? So if you see any of these injuries, and including the injury on the neck that is shown on the slide, we should be concerned for physical abuse right there and then. And this also, again, these green highlights would have been on the child's body on the left, and the red highlights would have been, again, on the child's body where the gray areas are, if you're able to see them. So basically, the suspicious bruises are on the trunk, front and back, including the abdomen, the chest, the buttocks, and on the backs of the thighs and the legs, and on the front thighs, and on the cheeks, on the bruises, on the bridge of the nose, and the internal aspects of the arms and shoulders. These would be without appropriate history of trauma concerning for physical abuse. And then we mentioned that devices to use for documentation is very important. Here is a high-end camera that I use to document injuries. And when I document an injury, I not only use a right-angle ruler, but also a topography identifier, so that when all is said and done, I'm not going to say, oh my gosh, where was this injury on the child's body? Okay, so this is the metaphyseal corner fracture that I mentioned earlier, and you didn't see the images. Notice that there is the bone, which is fine, but then there is this gray area, which is bone healing, which we call periosteal reaction. And then these fluffy gray-white areas, which we call bucket handle or corner, are fractures at the metaphyseal junction of this joint. Very specific for abuse, as well as rib fractures. New rib fractures and healing rib fractures that we see here are also very specific for physical abuse. And the mechanism for these fractures is usually an angry caretaker holding the child facing one another and squeezing the child's chest cavity, a lot of times in an incident of shaking. Vertebral fractures, the fractures of the spine, especially the posterior fractures, are very specific but relatively rare abusive fractures. Scapular fractures, shoulder blade fractures are also very specific, as well as, oops, we missed the sternal fracture. Sternal fracture is the chest bone fracture. These are also very specific when observed, but they are not very commonly seen. And whenever we see any of these injuries, we must look into whether we're able to establish this triangle or we're losing at least one side. Then we must start thinking of filing a report with Child Protection Services. A couple of examples about how the trauma history may fit or not fit what we observe. This child standing on the couch, if this is the history of trauma provided to me, may indeed fall off this couch, okay? I would expect, because the kid is less than 1 year of age, looking at the appearance, some adult would be in very close vicinity of the child so that, they can jump in and protect the child from falling. So we may consider supervision neglect if this child indeed falls off the couch and get some injuries. But this kind of a fall, especially falling onto a carpeted surface, should not lead to coma because there isn't enough acceleration and angular velocity to cause significant brain injury. It may cause this kind of a fracture if the child lands on the bent knee, for instance, a bruise or two, but even a skull fracture if it's a hardwood floor, for instance, onto which the child may fall from a standing position, but nothing else. If this child has metaphyseal fractures, when you do a skeletal survey, corner fractures, as we mentioned before, unexplained healing or healed extremity fracture, or a depressed skull fracture, or bleeding in the brain, then we must start thinking of physical abuse. This child playing on the top bunk bed, especially if they're playing here alone with no supervision, this kiddo over here on the left seems to be younger, that would definitely be supervision neglect in the U.S. laws at least. But even this kind of a fall would unlikely be able to lead to coma because of, again, not enough acceleration and angular velocity. But especially if this is hardwood floor, the kid may easily get skull fracture, subgaleal hematoma, which is bleeding in the scalp, and subdural hematoma, but we would expect that to be focal. Anything addition to these should raise concern for physical abuse. This, for instance, image shows subgaleal hematoma bleeding in the scalp, a skull fracture, and underneath that, a focal subdural hematoma. This kid may still be smiling, eating, drinking, everything fine and dandy. This injury, this constellation of injury, may be consistent with falling off a top bunk bed, especially onto hardwood floor. But if this kid is, and this may be the focal subdural hematoma, but if this kid has this kind of diastatic, widened skull fracture as a result of severe brain edema and being in coma because of this fall, or there is this type of big black brain which shows very severe brain swelling and subdural hematomas and multiple injuries on the scalp, etc., as well as on skeletal survey, again, a metaphyseal corner fracture, and especially retinal bleeding as shown here, then forget about it. This is a physical abuse case, not a simple fall off the top bunk bed. So post-consultation procedures are extremely important too, because in these severe cases, first of all, not only multiple disciplines will have to provide input, but also community agency staff, child protection services, police officers, even the prosecutors will need to be involved in the discussions so that we can hold a multidisciplinary interagency collaborative team meeting like this. Medical providers share the medical information, child protection shares the psychosocial issues related to the family, police provides the investigative knowledge. So as a result, we collaboratively make a decision on what needs to happen with this family. To sum up, child abuse and neglect requires a high index of suspicion, focusing on behavioral and physical indicators of abuse and the psychosocial history and the medical history we will obtain from the families and from the community agency representatives. In our diagnostic workup, collaborating with a hospital is extremely important so that skeletal survey, head CT, abdominal, chest CT, and MR and other X-rays that are helpful imaging tools can be conducted in the hospital setting with the input from a team that works very collaboratively and closely with the Barnahus team, and other tests that may be needed for the workup to diagnose physical abuse and to rule out differential diagnostic entities must also be available through that hospital setting. One last thing that I want to add here is in the United States, a lot of Barnahus facilities are established within a hospital. As a result, Barnahus team, especially the medical team of the Barnahus, in fact becomes the inpatient consultant team for physical abuse and acute sexual assault cases as well. In fact, that kind of a model is the most cost-effective model that eliminates miscommunications, lack of communication, and cases falling through the cracks. I think this was my last slide. I apologize for the technical difficulty, which Katerina resolved. And I will stop here. And
thanks so much, Resmiye. I also apologize. I think that sometimes Adobe, this software has a hard time with images, especially when they're like animated. There's an animation attached to them. So lessons learned for moving forward. No more animations. I think that could be it. Anyway, I think Stefan is trying to come back online with us as well. Before I get to the two questions that we've had, I'd like to encourage you to ask questions in the chat. There's still some time. Maybe we'll have some time to get to what you want, and if not, we can email you later. So Ruth asked a question earlier about a working example experienced in her past position where she wasn't sure how to act. She was working in a medical center for undocumented migrants where they were concerned for the welfare of 2 young children because of neglect, poor hygiene, physically small for their age. The mother allowed the doctor to examine her 2 older children who they were specifically concerned about, but the mother refused that the doctor examine the 2 younger children. They wanted to make sure all the children under her care were in good health. As we did not have suspicions around their particular well-being, it was difficult to insist that the mother allow the examination. What would you have done in this situation?
Yeah, that's a very good question. I think I would have found a culturally competent, same language person to communicate with the mother to understand what her concerns were about the examination of the younger 2 children. I mean, sometimes people who have concerns about the injuries on a child's body, if they know that the system will get involved, may refuse physical examination. But there may also be some reasons that we don't understand that has something to do with their culture. And when we understand their concerns, if it is something that we can eliminate, the concern I mean, we may explain the situation to calm them down, to get permission from them. And sometimes it may be an educational opportunity, whatever concern they have, maybe some kind of a superstition and this and that. Again, with the help of somebody that understands their culture, preferably that is from their culture, we may help educate that person. That's a possibility. And sometimes elderly people may control the culture in families coming from certain cultures, and engaging them in the conversation may help as well. It may be that a mother-in-law at home might have said, don't you ever have anybody touch these two babies, and then she might be following her instruction, and we may have no control over that.
Jared has asked if you have been mistaken about a diagnosis, and what was the background? Or vice versa, I suppose, yes.
Oh, you mean diagnosing physical abuse when it was not physical abuse, or... Okay, let me share with you a very good example. When I was a junior faculty here in my first year, a child came to us about 9-10 months old, with a very big subgaleal hematoma. And subgaleal hematoma is bleeding in the scalp, which gives a copper-like color to the forehead and upper portion of the cheeks and the entire head. But the child didn't have anything else. It was just that subgaleal hematoma. No bleeding in the brain, no skull fracture, and the history of trauma was the child was sitting on the father's lap and made a jerking backwards movement, and the father lost grip of the child, and the child fell backward, had an impact on the head, but had only the subgaleal hematoma, nothing else. And when I was examining the child did that exact same jerking movement backwards. I caught the child, otherwise he was going to hit his head against the metal railing of the crib he was in. So having observed what the father was telling me, I said, okay, I have the triangle, right? The Oral's triangle is there. History of trauma, child's developmental level, and extent of the injury. All fit together, and I said there's no reason to file a report to DHS on this case. This is an unforeseen accident. And then 2 days later, I got a call from DHS, Department of Human Services here, and DHS said they got a call from a neighbor, and the neighbor said this was a drug home. The parents were doing drugs, and the kids were on their own, and they were very concerned for the well-being of the children. Okay? So that taught me I was concerned about the size of the subgaleal hematoma. It was huge. But then the guy's example made sense too, but the child was very young, under 1 year of age. I still should have filed a report with DHS. And I felt so happy that somebody from the community.
Thank you. You know, I just got word that actually, so Stefan hasn't gotten his video back, but he is still with us via voice. Stefan, perhaps I give you the last word. What reflections do you have on today's presentation, and do you have anything to add to the questions that were just asked?
So thank you. I hope you can hear me. I've lost contact, unfortunately, via video, but thank you, Resmiye, for a very good talk and structuring the points about physical abuse really well. I just want to comment really on the last that you talked about the child that you sort of saw doing the things that it did, and it made sense to you. I think it's very good. You talked about having a protocol for all children that come with injuries at the hospital, and just follow the protocol and just do as you always do with every injury, that this is our protocol. We make a report to social services because it's this kind of injury. We don't think so much maybe how the injury is sort of obtained. It's just an injury that could be caused by, and we do it with routine and follow our protocol. And usually that sort of makes sense also to, and getting a better sort of this is how good we are. This is what we do, because we have the protocol, we follow that, and that sort of makes it easier to pick up these children, even if it's someone who doesn't really work with this kind of children always. Thank you.
Thank you, Stefan.
Thanks so much. We have one more question about
Thank you,
triggering the child when, I guess, in the evaluation phase. Re-traumatizing the child during the medical evaluation.
Sorry, I didn't get. Okay, yeah, that's a very good question too. Well, in the U.S., we have a support system that is called child life specialists. So in every inpatient unit, there are child life specialists, especially when there is a difficult procedure, blood drawing, or the kind of examinations that we do. We invite the child life specialist to join us, to engage the child, and also we medical providers take our time. For instance, when I go into a room after having met with the family, having taken the history, I approach the child right away, and most of the physically abused children are young infants. I put my hand on their heads and rub their cheek a little bit. If they're very, very young, put my finger in their palms and they grab it right away and try to connect and, you know, talk with them in a very nice, mellow voice and make it as problem-free as possible. And Child Life and the nurse are also great support in doing that. In older children, I explain to the child in great detail what I'm going to do. I make sure they understand nothing is going to hurt in my examination. I'm just going to touch you. I hold their hand just like this. Does this hurt? No, it doesn't. And this is how I'm going to do. I'm going to touch your arm, your hands, your legs. I'll look at your face and your head. I'll listen to you. Explain everything in great detail, showing all the devices and making sure I repeat time and time again. There's no needle, no shots, no hurting. And if you feel uncomfortable when I examine you, tell me. I will stop right away. And I do. I give them time, and then they calm down, and then we try one more time. And with this, to tell you the truth, I haven't had any child that refused examination or screamed bloody murder. It goes perfectly fine. Perhaps in resource-limited countries, especially educating your nurses to become your.
That's absolutely brilliant. Thanks so much, and thank you for the question. It is an important consideration, of course, in these sensitive situations. I want to thank you all very much for joining us today. I would like to thank Stefan for his contributions at the end, and for he agreed with you completely, Resmiye, with what you just said in terms of the experience there. And of course, Resmiye Oral from the US, thank you so much for not only giving your consistent and enthusiastic support in Promise 1, but continuing to stick with us in the second phase. And you're always a brilliant, shining face and a warm person to speak to. So thank you for being with us. Yes. Yes.
May I say something? My friends, obviously, what we're doing here is just a tiny little introduction to medical piece in child abuse evaluation. I do a lot of international training and systems building work. If anybody would like to work with me, I come to Greece every year and Turkey every year as well. I would be more than happy to do a side trip to any country that is represented here.
That's absolutely brilliant. Thank you so much, Resmiye. And again, thank you, everyone. I turn it over to Child Hub team for a final word. Thanks so much.
Thanks a lot. And I really don't want to keep any of you. I just want to thank to the whole team for this wonderful webinar. And as Resmiye just said, the more we are getting into this topic, the more questions arise. And I really appreciate the fact that we can get into the details. And I would like to encourage our listeners to join us for the next webinar. And if Shana, if you could put that back on the slide, maybe the time of the next webinar. Yes, the 19th. So that's the third and last part of this mini series. So we hope you will join us, and thank you very much for being with us and for the wonderful discussions. Bye-bye.
Ciao.